Good morning, madam.
सुरू करायचं का? बरं. काय म्हणजे हा ओके. हा.
Good morning, everybody. We would start, we'll wait for another 5 minutes for others to join, and we'll start exactly at 11:05. Request to everybody, please keep yourself on mute, please.
तीन बार आहे आता दोन अरेंजमेंट आहे वाटते.
Good morning, everybody. We have none other than Dr. Rohini Samant. I am sure most of you know her. She does not really require an introduction. She is a senior consultant rheumatologist at PD Hinduja Hospital. She is also the president of. Can you please keep a request to everybody? Can you keep yourself on mute, please? Ankita, Lalna madam, and Nalini. She is also the president of MRA, and the entire PG training session is her initiative. Let's have a look at ANCA vasculitis today. As I just posted in the group, this is a very important topic, otherwise also in clinical practice. And if we look at from the PG training perspective, it's an important long case and probably a difficult long case. So let's have a look. Over to you, madam.
Thanks, Shashank. Am I audible?
Madam, yes.
Yeah. So should I start sharing?
Yes, madam. Madam, your screen is seen. Only make it full screen right now.
Huh. That's okay. I think there is someone needs to be muted. Can you all please mute yourselves, all the participants? And of course, I don't want you to be mute all the time, but I want questions. But right now, I think there's some horn and car beeping sound. So please mute yourselves.
So I'll also ask the agency person to do that.
Yeah. Okay, so should I start now, Shashank?
Yes, madam, please go ahead.
I can hear a lot of sounds, so I
Yeah.
was waiting for it. Yeah.
Nalini, I think the sound is coming from your end. Can you please mute yourself? Nalini?
Yeah, hello.
Yeah,
Hello.
mute yourself.
Please mute.
You can go ahead.
Guys, I have muted all of them.
Yeah, great, Prasad. Thank you.
Okay.
Madam, you can go ahead now. Madam, you'll have to unmute yourself. Sorry, we can't hear you. Basically, the agency person muted everybody. That's why you'll have to just unmute yourself.
Okay.
Perfect, madam.
Huh. So, so I'd like everyone to be also unmuted at a later point in time, because I don't want this to be just a one-sided talk. And definitely at the end of the talk, I would really welcome questions and interaction. So this is a difficult topic at the postgraduate level, and because we don't see too many cases at this stage. And therefore, I would like to go through a little bit of revision. And I know Dr. Rahish Ravindran has taken you through an approach to vasculitis last time. And I'd just like to take you through it in a couple of slides, and then we move to our main topic. So vasculitic syndromes, what happens in vasculitis? That there is inflammation of the blood vessels. It's a simple definition. And that inflammation may lead to necrosis of the blood vessel, and then later occlusion and ischemia of the tissues supplied by the involved vessel. So not really very difficult to understand. Uh, now, is the heading visible, Shashank? Or
But
it's
we can
covered by...
see the slide, but one, it is not in full screen, and if you're moving, the slides are not moving. It's still on the first slide, just in case you're moving.
No, I'm moving the slides actually.
Madam, can you stop sharing and reshare again once?
Okay.
Perfect, perfect.
Now it's good?
Yes,
Hmm.
yes, perfect. Yes.
Okay. So vasculitic syndromes, as I just mentioned, they are characterized by inflammation and necrosis of blood vessels, leading to ischemia and occlusion of the vessels. Not always, but often. Okay. So now this is not moving forward, Shashank.
Or can you mail me the PPT? I'll share it from my end immediately.
Okay.
I'll,
So
in
now,
this chat, I'll put my email ID.
I'll just try once again. I'm mailing it to you as well.
Yes.
So can you see the slides now?
Yes, madam. Go ahead. Let's see.
So I'll move
Slide
ahead.
is same.
Okay.
Yeah.
Yeah.
Perfect, perfect.
I was just wondering whether you can see the title because it's being
Yeah, yeah,
covered
yeah.
by, it's being
No, no,
covered on my side.
no,
by
it's
sa-
seen. It's seen,
Okay,
madam.
okay. So if you, we talk about vasculitis, I think Dr. Rahish Ravindran has taken you through the approach to vasculitis. And here you can see that, we have this large vessel involvement in Takayasu's, and then the medial vessel vasculitis, which is quite rare, polyarteritis nodosa. And what we are going to focus on today is the small vessel vasculitis. So here, these are the medium-sized vessels, which are the renal arteries. And then you have the smaller vessels, the arterioles, or the smaller arteries, arterioles, the venules, all of which can be affected in the ANCA-associated vasculitis. Okay? And ANCA-associated vasculitis, there are three main types: the granulomatous with polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. Now, again, just a little revision of when does one think of vasculitis. So we should be able to recognize that possibly this looks like vasculitis. So recognize vasculitis. There are other conditions which can cause vasculitis. We need to rule them out before we say that this is a primary vasculitis like the ANCA associated vasculitis. See, and what helps us in doing that, the pattern of the vessels involved and what are the characteristics of each primary vasculitis. So we'll go through these steps. Now, any systemic vasculitis like the ANCA associated vasculitis, usually there are constitutional symptoms. So the patient is often quite sick with fever, weight loss, malaise. And in addition, there are these vasculitic lesions which can affect different organ systems of the body. And here we have to be aware of what happens when there is vasculitic involvement, say, of the ear, nose, throat, the skin, the muscle, the peripheral nerves, the lungs, kidneys, etc. Okay. So what should arouse this suspicion of vasculitis? When you see lesions of palpable purpura, I'll show you a few pictures. When you see fleeting or shifting lung infiltrates, when you see that the urine picture is suggestive of hematuria or proteinuria, right? And when there is a sudden weakness of in the distribution of the peripheral nerves, like a new ulnar claw, a foot drop which happens suddenly, that is mononeuritis multiplex, okay? Unlike peripheral neuropathy, which is very slow. ENT, you can get epistaxis, nasal stuffiness, hearing loss, and any unexplained ischemic events like a digital gangrene, infarction of the bowel, okay? Myocardial infarction in a, say, very young patient with no risk factors. All these should arouse suspicion of vasculitis, okay? And these are the various things. So you have these raised, tender, nodular lesions on the leg, which are palpable purpura. You have these infiltrates. Now, mind you, in our country, of course, we have to rule out other causes. And when we come to the definitions or the classification of vasculitis, we'll see that unless we rule out other conditions, we cannot really say that this is due to vasculitis. But you can see shifting pulmonary infiltrates. You can see cavities in the lung in patients with lung vasculitis. Okay, this is the classical ulnar claw. Okay. You must have seen this in patients with Hansen's sometimes. So that remains the first cause in our country, but in a different context, it may also indicate vasculitis. Digital gangrene, hematuria, okay, presence of CAS, RBC CAS, and a sudden foot drop. So these are some of the examples that should make you consider that maybe this patient has a vasculitis. Now, mind you, vasculitis doesn't necessarily mean that it is a primary vasculitis. There may be some infections which can lead to vasculitis. And in our country particularly, we have to be very wary and very alert to these possibilities. Okay. So conditions like infective endocarditis, you know that there can be splinter hemorrhages. There can be digital ischemia in infective endocarditis. Okay. TB sometimes can mimic a systemic vasculitis, chronic viral hepatitis, and I'll show you an instance of that. Sometimes a patient with a myocardial infarction with atherothrombosis, okay, an LV clot with atherothrombotic disorder can mimic a vasculitis. And of course, other connective tissue diseases which are associated with vasculitis have to be kept in mind, particularly SLE, rheumatoid arthritis, Sjogren syndrome, cryoglobulinemia, etc. And also, when you see a very acute case of vasculitis, look at the drug history. Okay, some of the drugs, the antithyroid, the thyrotoxic, the drugs used in thyrotoxicosis, carbimazole, etc., can be associated with vasculitis. So be alert to the possibility that this vasculitis may be secondary to something else. It's not just a primary vasculitis. Now, this is an example of one of our patients who had hepatitis C and cryoglobulinemia secondary to that with a digital ischemia. So, this was cryoglobulinic vasculitis secondary to hepatitis C. Now, look at the pattern of vessel involvement. So, is it an aortic involvement? Suggests Takayasu, giant cell arteritis. TB also can cause aortitis, mind you. Is it an involvement of the small vessels, the venules, etc.? Only the small vessels being involved? This could be a primary systemic vasculitis of the ANCA type. And learn the characteristic presentations of each vasculitis. And this is what we will discuss today regarding ANCA vasculitis. Okay. So the ANCA-associated vasculitis, I already mentioned, there are three types. That is the granulomatosis polyangiitis, the microscopic polyangiitis, and the eosinophilic granulomatous polyangiitis. So now all this, I will try and do it slowly so that we don't get mixed up. But if you look at granulomatosis polyangiitis, what was earlier known as Wegener's granulomatosis, here you have predominant ENT involvement. You have lung involvement and you may have renal involvement with eye involvement. Okay. With the EGPA or the Church-Strauss, what was known as Church-Strauss vasculitis, asthma is a very important past history. Okay. So you must ask a past history of asthma, lung involvement, heart, cardiac involvement, which is quite unique to EGPA, and microscopic polyangiitis, where predominantly the kidneys, the lungs are involved, and also sometimes the peripheral nerves. Okay. Now, what is the epidemiology? Why? These are rare diseases. I'm sure many of you may, in your first or second years, may or may not have seen a case of ANCA vasculitis. Okay. So the prevalence is only 200 to 400 per million. Okay. So it's much less than 1%. It's much, much less than that. It's 0.02%. Okay. And however, because we recognize these conditions more because of the testing that is available, because of classification criteria that make a diagnosis probably earlier, we are recognizing more and more of these conditions. And it's very important to recognize them because they can be fatal if they are not treated properly, right? They affect males and females equally, unlike most of our other autoimmune diseases where you find a female predominance. And typically, the Wegener's or the microscopic polyangiitis affect older adults, while the eosinophilic or the Church-Strauss tends to affect younger patients, right? And in India, in the world, the microscopic polyangiitis is more common in Eastern Asia, while GPA is more common in Europe. Now, at Nair, when I was at Nair, we did a study and we found that of the total patients coming to Nair for rheumatological conditions, 1% had a diagnosis of vasculitis. So this is, mind you, a very select population. And even in that, this is 1% not ANCA, but just vasculitis. So it's a rare condition. Now, pathogenesis, without going into too much detail, but giving you just an outline of what happens in ANCA vasculitis. So what is important is that there is a genetic predisposition to these conditions, and an infection can sometimes trigger in a predisposed individuals. Drugs can act as a trigger in a predisposed individual. What does this predisposed individual have? There are some defects due to which there are autoreactive T cells, which these people with genetic predisposition have. What do these autoreactive T cells do? They give help to the B cells, okay? And the B cells produce what we know as the ANCA antibodies or the anti-neutrophil cytoplasmic antibodies. Now, these antibodies go and attach to the neutrophils, okay? And when they attach to the neutrophils, they set off a cascade of inflammation. okay, what is known as netosis, okay. And this netosis goes and affects the vascular endothelium, causing damage to the vessels and inflammation of the vessels, leading to what we said earlier, that there is occlusion and ischemia of the affected organs. Now, mind you, the alternate complement activation also occurs when the neutrophils are activated by the binding of the anti-neutrophil cytoplasmic antibodies. Okay. So this is in a very nutshell, what happens in ANCA-associated vasculitis. Now, I will take you through the classification criteria, not too much in detail, but just to understand a few how classification criteria are actually laid down. And these are the more recent criteria laid by the American and European societies, right? Now, I want you to understand one very important dictum, that these criteria are actually meant to be applied only when patients already have been diagnosed with a vasculitis. Now, is this ANCA vasculitis? That is what these criteria are going to help us with, okay? And the second very important thing, like I told you, that, infective endocarditis can cause vasculitis. So one has to exclude alternate diagnosis before we can actually apply these criteria to any of our patients. And I think this is a point which cannot be overemphasized enough, that if we see a vasculitis, we cannot start on steroids unless we are sure that we have excluded infections or vasculitis mimics. So for GPA, there are few criteria. And if you look at these criteria, we look at it a bit cursorily, not in too much detail, but you can see that positivity for ANCA forms 5 points, okay? And we need a score of more than 5 for the diagnosis of ANCA-associated GPA, right? And the other points that are there are the nasal inflammation leading to epistaxis, nasal crusting, inflammation of the nasal cartilage or of the ear cartilage, the presence of acute conductive or sensory neural hearing loss, okay? And then certain areas which may be biopsied, for example, if there is inflammation or granulomas in the lungs, you may do a lung biopsy or a kidney biopsy. And if they show the characteristic inflammation of the blood vessels or glomerulonephritis, then that is suggestive of a granulomatous polyangiitis. But bear in mind that exclusion of other conditions, and already you have diagnosed this patient with a vasculitic presentation, and then you are applying these criteria, okay? And these are some of the examples. Maybe you have seen a few. There is inflammation of the cartilage of the ear, okay, and there is some necrosis here, you can see. There are these cavities, okay, in the lungs. Now, remember that we'll come to that later again. Presence of oral ulcers, presence of ocular inflammation in the form of scleritis. This is a depressed bridge of nose due to inflammation of the nasal cartilage. And this is a characteristic but very infrequently seen, mind you. So where you are seeing a granuloma on the one hand, and you are seeing an inflamed and occluded vessel on the other hand. So mind you, even if we call it granulomatosis with polyangiitis, you do not always see granulomas, okay? So you have to look at it in the context of the entire clinical picture, and that is why those points for classification. So some of these things may not be present, right? Now I'm going to take you through a few common features of Wegener's or granulomatosis polyangiitis. And so bloody nasal discharge, epistaxis, nasal crusting. So the patient says that my nose feels very stuffy, I need to keep clearing my nose all the time. Okay, there is sinusitis on imaging, right? And there is sometimes an acute hearing loss or sometimes a gradual hearing loss. And subglottic inflammation we will come to. It's a very unique feature of granulomatosis polyangiitis. You can get oral ulcers, which often heal quickly with treatment. This is something rare but very unique. So if you see gums which are extremely red and inflamed, that is one of the features of GPA. And rarely, in about a small percentage, you can see parotid gland inflammation. Now, this is what I was telling you, that the patient develops breathlessness, but there is what we know as a stridor. Do you understand what stridor is? So there is a sort of, when the patient breathes in, you can hear the sound of the air passing through an obstructed passage. That is what is called as stridor. And this is because below the vocal cords, these are the vocal cords, there is an inflammation of the subglottic area. So this is quite unique to granulomatosis polyangiitis. Now, lung involvement. In our country, we have to be very wary of TB. Okay, we often see cavities in the lungs. I showed you the pictures. Okay, we see pulmonary infiltrates, which can be seen in TB or some fungal infections. And sometimes there can be damage to the bronchi leading to bronchial stenosis. Eye involvement is also not very rare, as you can see that it can be seen in about 15% of patients, that they may have episcleritis or inflammation of the sclera, superficial layers of the sclera, or they can be swelling of the entire eye due to orbital pseudotumors. So eye, ear, lungs, all these should alert you that perhaps we are dealing with a GPA. Okay. Now, the renal involvement, characterized by proteinuria, hematuria, RBC casts, and if there is a rapid involvement of the glomeruli due to crescent formation, then the serum creatinine can rise. Okay. And that is called a rapidly progressive glomerulonephritis. Okay. So just taking you again through some of the pictures. And now moving on to the microscopic polyangiitis. Okay. Now this is relatively rare. The GPA is more common. And here, again, there are, certain negative criteria also. We won't discuss too much about this. But what is given a lot of importance is the presence of P-ANCA positivity. Okay, P-ANCA, whereas the C-ANCA was positive in the granulomatosis with polyangiitis. And what you see is again a glomerulonephritis on renal biopsy. There can be a rapidly progressive glomerulonephritis and an ILD-like picture. Unlike the cavities and the fleeting infiltrates which were seen in Wegener's, you can see sometimes an interstitial lung disease in patients with microscopic polyangiitis. Okay. Cutaneous involvement, although the criteria do not include this, but you can also see cutaneous involvement in the form of palpable purpura, a leukocytoclastic vasculitis. This is quite characteristic. Necrotizing glomerulonephritis, okay, with a necrotizing vessel involvement, and lung involvement in the form of lung infiltrates, lung hemorrhage, interstitial lung disease. Okay. Now, I'll later ask you what you made of this X-ray, okay? Or maybe I'll have to tell you right now that this is an X-ray which actually shows an inflammation of the vessel which bleeds into the alveoli, causing an alveolar hemorrhage. It's quite dramatic. The patient comes with this X-ray. He may or may not be very breathless. But this X-ray in the context of a patient having vasculitis arouses a suspicion of an alveolar hemorrhage. So there is bleeding in the lung alveoli, which impairs gas exchange. Sometimes if it's very rapid, it can lead to breathlessness and even respiratory failure. And this is a slide showing crescent formation. Okay, crescent formation. Now, this is again both seen in the GPA and the microscopic polyangiitis. And mind you, unlike lupus, which probably you have seen more patients, wherein if you look at the immunofluorescent microscopy, you will see a lot of antibodies, okay, the IgG, the C3, But here, this is called a posse immune. So you don't see too many immune deposits. Okay. And then these are the criteria for eosinophilic granulomatosis, or what you may have learned as Church-Strauss disease, right? What is very unique to Church-Strauss or eosinophilic granulomatosis is that there is a history often of asthma in these patients, okay? And there is an obstructive airway disease. There may be nasal polyps, again an allergic phenomenon, and mononeuritis multiplex is common in this condition, as is in GPA, right? But what is also very characteristic is the presence of a very significant eosinophil count, total count more than 1,000. And on a biopsy, you might see eosinophils, extravascular presence of eosinophils on the biopsy. Okay. So, if you look at eosinophilic granulomatosis, again, you have the asthma and which I mentioned. But what is also very less common in the other vasculitis, which is seen in EGPA, is the cardiac involvement. Okay. And also sometimes involvement of the gut. So you have mesenteric ischemia. So if you get a reference from surgery and there is this patient has an ischemic bowel and there is no other reason, obvious reason, think of a vasculitis, okay, which and you must work up that patient for a vasculitis, okay. So here you see an eosinophilic infiltrate around the vessels in patients with Church-Strauss vasculitis. What are the common tests and what do they reveal in patients with vasculitis? So here on the hemogram, you will find thrombocytosis. So mind you, whenever you see thrombocytosis, the common things that come to our mind is anemia or blood loss. But when you have an autoimmune condition and you see thrombocytosis, do think of rheumatoid arthritis or think of vasculitis as one of the possibilities. Okay. You see a leukocytosis. Unlike lupus, where you see a leukopenia, right? Then you see a high ESR, high CRP, a raised creatinine. If you have did I tell you? If you have a rapidly progressive glomerulonephritis, the creatinine can rise rapidly. Okay. Urine microscopy shows hematuria, proteinuria. Chest X-ray is warranted. PNS if there are symptoms of the paranasal sinuses, right? Stuffiness of the nose, epistaxis. HRCT to further delineate the lung involvement. Alveolar hemorrhage. The CT findings may suggest an alveolar hemorrhage, okay? CT of the paranasal sinuses. An MRI of the heart in Church-Strauss if there is involvement. Nerve conduction studies if there is a sudden foot drop. Okay, a nerve biopsy may be done in that context of the sural nerve. Okay, a renal biopsy, a skin biopsy, and other tests to rule out vasculitis mimics. Okay, now these are quite a few tests which I don't want to go into. You want to rule out infection sometimes. So you might do a sputum examination, you might do a bronchoalveolar lavage, a blood culture. Okay, so several, like I mentioned, that some of infections can mimic vasculitis, and we need to, in the right context, do the relevant tests. Now, to look at ANCA antibodies, what are these? These are antibodies which are produced obviously by the autoreactive B cells and which react with enzymes present in the cytoplasmic granules of human neutrophils. And the PR3 ANCA or the C ANCA are against proteinase 3, and these are against myeloperoxidase. Immunofluorescence is used as a screening test, but then there are specific ELISA tests for PR3 ANCA and MPO ANCA. Okay, P ANCA is seen more in microscopic pan, and C ANCA is seen in granulomatosis polyangiitis. And whether, if the titer of ANCA increases, it means that this patient is going to relapse or that there is a disease flare that is going to happen. It's not always a linear correlation, but it may predict a relapse. So, and an ANCA alone may not suffice in diagnosis because there are false positives and it may need confirmation with a biopsy of the tissue like the kidney or the skin, etc. Right? So again, just this is a repetition, but there is something called atypical ANCA, which is seen in a variety of autoimmune conditions, mind you. So just if you see an ANCA positive, don't jump that into that this is a diagnosis of GPA or a MPA, right? C ANCA is relatively specific for Wegener's and P ANCA for microscopic polyangiitis. And if you look at sorry. So it's not moving forward.
But just press escape once or the next area. Next on that will also good. Next slide on that.
This maybe.
Or just escape.
Huh.
So now the next
Okay.
slide.
So now here you can see that ANCA is negative in Churg-Strauss in about 30% of patients. So mind you, in Churg-Strauss, you may not get ANCA positivity in a large number of patients. And even in microscopic polyangiitis, you see MPO ANCA only in 50% of patients. So there is ANCA is not necessary always for the diagnosis, but it's an important one if it is present, right? So renal biopsy, this is a repetition. You have necrosis of the vessels, which is very characteristic of vasculitis. So the blood vessel layers are just due to the inflammation, they get necrosed, okay? And granulomatous vasculitis is only seen in a small number of patients. Not always do you see that. You can do a sural nerve biopsy, a lung biopsy, muscle, if there is a lot of muscle inflammation, right? And I won't go into these, but when now people are studying vasculitis, so when they want to compare whether the results of treatments, etc., they have formed certain indices to measure the activity of the disease. Okay, so for example, if there is a new skin rash, it means that this is an active disease. Whereas if you just see a remnant of the rash, then it is not active disease. Or and then there is sometimes damage due to the disease. So all these things are measured by people who are studying vasculitis and the therapeutic impact of different treatments, right? Now, just this is again going through what is more common in which vasculitis. So you can see again that Churg-Strauss, the peripheral nerve involvement is common in almost all, but more in Churg-Strauss and in the microscopic polyangiitis, whereas the ENT involvement is really very common in Wegener's granulomatosis, the ENT and the lung involvement. And the kidney involvement is more common in the microscopic polyangiitis. As I mentioned earlier, the heart is involved in a lot of patients with eosinophilic granulomatosis, right? Now, when we are contemplating treatment of these patients, we need to divide these patients into categories. So, do they have localized disease? For example, you may have a patient who only has nasal stuffiness, running nose, and epistaxis, and some ear inflammation. Okay, so this is disease which is localized to the ENT region. Or is it a more diffuse disease with other organ involvement like the kidney or the orbital involvement? Are there B symptoms present? So does the patient have fever, weight loss, malaise? Okay. And in the case of renal involvement, what is happening to the creatinine? So all this categorization helps us in treating the patient either less aggressively or very aggressively with use of treatments like plasmapheresis when the disease is extremely severe. So this is just for you to have an overview and understanding. You need not go into too much detail of this. And this is a little busy slide, but I will try and make it easy for you. So this is, like I told you, that this patient has only ENT involvement and maybe a little bit of lung involvement, but it's not severe lung involvement. Okay. So what are we going to do with this patient? We can just treat this patient with glucocorticoids. Of course, glucocorticoids form the mainstay of most treatments. And milder immune suppression with drugs like methotrexate, with drugs like azathioprine, okay, with drugs like leflunomide sometimes. But if you have a very active disease, for example, the alveolar hemorrhage, which I showed you, or a rapidly progressive glomerulonephritis, then you would treat such patients with rituximab or cyclophosphamide. Okay. Now, if you are able to induce a remission after this initial treatment, then you need to maintain these people on drugs. And the options for maintenance are drugs like rituximab, again used 6 monthly, azathioprine or methotrexate or leflunomide. Okay. Now, you must have heard of a drug called mycophenolate mofetil. It is not preferred for maintenance because the relapse rate is quite high on mycophenolate mofetil. Okay. If you have a very severe organ-threatening disease, particularly the kidney, plasmapheresis may be used in those situations. Okay. And similarly, when the patient relapses on treatment, which is quite common with Wegener's, then if the patient, you have used cyclophosphamide for initiation, then you may switch to rituximab. Or if you have used rituximab for initiation, then you may switch to cyclophosphamide. Now, in a milder disease, again, the remission may be maintained on methotrexate, azathioprine, or leflunomide. And sometimes, if the involvement is a little more severe, you may still use rituximab for maintenance treatment. So again, just to summarize, for mild disease, a lot of oral medication sometimes suffices with methotrexate, azathioprine. And for more severe disease, cyclophosphamide in combination with rituximab, or cyclophosphamide alone or rituximab alone in combination with steroids. So this is just to give you an idea about two important studies which took place, which brought rituximab in the picture for treatment of ANCA-associated vasculitis. Earlier, ANCA-associated vasculitis was being used, only cyclophosphamide and steroids were being used. But these two important trials, and we won't go into details, the RituxVas and the RAVE study, they showed that rituximab is equally efficacious and sometimes even more efficacious than cyclophosphamide, particularly for relapsing disease, both granulomatosis polyangiitis and microscopic polyangiitis. So this is a very, very important new entrant into the treatment of granulomatosis or ANCA-associated vasculitis. And this is a new drug. I'm just referring to it, just one word, that avocapan. We mentioned earlier that the alternate complement pathway is involved in the pathogenesis of ANCA vasculitis. And this is a drug which has been used for maintenance of patients with ANCA vasculitis, even without steroids. Okay. So we are moving to lesser and lesser use of steroids in patients with vasculitis. And this is one of the options for maintenance, right? Now, when we are treating patients with steroids, with rituximab, cyclophosphamide, there are a few things that we must keep in mind. We may use cotrimoxazole or Septran, what we say, for prophylaxis, particularly against PCP. When we are using a lot of pulses of cyclophosphamide, Mesna particularly when we are using higher doses of cyclophosphamide, we may use Mesna because cyclophosphamide may lead to hemorrhagic cystitis and bladder cancer with multiple uses. And so in more recent times, we use less and less of cyclophosphamide. Of course, in certain situations, we have to use, when it's a very severe disease, we have to use higher doses of cyclophosphamide. Bring down the steroids as early as possible to low doses. In elderly patients with risk factors for osteoporosis, bisphosphonates can be used prophylactically, particularly with lung involvements or even otherwise, vaccination to prevent influenza, pneumonia, etc. when these diseases affect young people who have not yet had their families, Overman sperm banking should be done in today's context. So these are some of the things that we can use to optimize our treatment. Okay, in patients, apart from the drugs that we use, these are the other uh, strategies that should be used. And what are the markers which indicate a poor prognosis? Patients who are older in age, with kidney involvement, with an increased creatinine. So already the patient has come with a creatinine of 4, right? Severe pulmonary manifestations at diagnosis. Now, ENT involvement is supposed to be protective. So if someone doesn't have ENT involvement, actually it's a poor prognostic marker. Okay. And usually remission occurs in less than 6 months of treatment. However, there is a very high relapse rate, particularly in granulomatosis polyangiitis. It's about 18 to 40%. Within the next 2 years of the patients, there is a higher chance of relapse. And therefore, now the strategies for relapse, use of rituximab every 6 months, use of azathioprine, and there are several guidelines for the same. Okay. Now, mind you, what do these patients die of? So, you are mistaken if you think that they die only of the primary diagnosis. They die not only of the primary disease, but particularly in our country, sometimes in the lower socioeconomic strata, when you are using a lot of immune suppression, you see a lot of infections, not only in the lower, but also in the upper, but more common in the lower. So PCP infections, tuberculosis complicating treatment, other bacterial infections with the use of cyclophosphamide and rituximab, all these are also very important causes of death. Okay. And with the use of drugs like cyclophosphamide, there is a little higher chance of malignancy at a later date. But you must remember that the disease per se and infections can kill the patient, right? So this was my last slide. I have tried to give more time to discussion, and I hope there are questions regarding the presentation or any other questions regarding patients which you may have had, which I would be happy to try and answer.
Thank you, madam, for simplifying a difficult topic. Uh, we are open to questions now. You can post the questions in the chat. Kindly share presentation PPT. Dr. Banraj will take care of that. Madam, can you talk about a little bit about secondary vasculitis, particularly when there are infections to secondary vasculitis?
Should I go to that slide again?
Because that is something.
So I would like to ask the audience also, have you had a case of infection-related vasculitis? Has anyone seen a case of infection-related vasculitis?
You can unmute yourself and go ahead. Anyone?
Hello.
Yes.
Rohini, this is Nitin Karnik. See,
Nitin. Hi.
now what many times I wonder is every time after Mumbai floods, 8 to 10 days later, I have a spurt of cases of febrile illnesses with lung hemorrhages, and almost 15 to 20 such cases come very bad and die within 12 to 24 hours. Occasionally, the PCR turns on admission, all those fever workup is negative. We send a PCR to Kasturba, and 3 4 days later, a few of them, maybe 10-20% of them, turn out to be lepto PCR positive.
Right.
But they have that fulminant hemorrhagic ARDS. I suspect this is all vasculitis. A secondary vasculitis related to some infection, maybe virus or that lepto. But there's a large chunk of undiagnosed cases, but it is infection-related vasculitis and fulminant deaths.
Absolutely. I mean, I couldn't agree more with you because, I mean, there are so many viruses that we are really unable to actually nowadays with the use of biofires, probably we may be able to find out a little bit more. But I agree that they are definitely vascular inflammation secondary to infections. The other thing that maybe in the pediatric age group or in younger patients, one often sees is a sepsis with a DIC.
Yeah.
And many of you might have seen that there is gangrene, and but this is a septic into inverted commas vasculitis, a DIC causing actually a thrombotic occlusion of the vessels secondary to sepsis. So that is something which I think physicians probably would be seeing a lot of, right? And tuberculous vasculitis, I think one of the most common things that we see is a stroke, isn't it? When we see a
Yeah.
brain tuberculosis. In other areas, tuberculosis causing a vasculitis is more of aortitis, okay? So although now we say that Takaisos is actually an autoimmune disease, but we know that tuberculosis can also be a cause of aortitis, right? So that is one of the important this. Then in the pediatric age group, sometimes post chickenpox, you get a stroke, okay, due to post chickenpox vasculitis. So infective endocarditis, I mean, that is something which I think all of us, at least in the public hospitals, must be still seeing quite a lot of. And so that can really mimic um, a vasculitis. So I think vasculitis mimics, we have to be very alert to, before we. So I'm glad that, the classification criteria also spell it out that other causes have to be excluded before you actually go onto that path of the. When hepatitis C was not being treated as well as it is now, we have seen a lot of hep C related autoimmune conditions. And that patient which we showed was like, over the years, this patient was moving around, and then we got a history of 20 years or 25 years ago blood transfusion. And this patient had a cryoglobulinemic vasculitis. So I think I cannot emphasize enough that, other causes have to be thought of. Drugs also, sometimes we don't look at drug lists, no, which the patients are taking. Not only for vasculitis, but even for lupus and, other conditions where the drug may be causing some havoc.
A question from Priyanka Thakur. If patient of ANCA vasculitis is having increased WBC, but no source of infection found, can we start immunosuppression in this patient if the patient is worsening day by day?
Worsening in what way, I would like to know, Priyanka. But I would say that, a high count is one of the things. And you would definitely also want to maybe rule out infection. But if your organ which is involved due to the ANCA vasculitis is getting worse, then obviously that itself calls for stepping up of treatment once you have reasonably ruled out infection. Regarding infection, because you come to the topic of infection, I would, really like to emphasize again that whenever there is lung involvement, do not hesitate. Often our pulmonologists do not help us. I know that at Nair it used to happen that they would be hesitant to do a BAL. I mean, you pick up so many infections, opportunistic infections when you do a BAL. So just do not hesitate to do that at the earliest opportunity that you get. Okay, because after some time, the patient gets worse, the BAL becomes even more difficult. So I think you have to be very, pursue that infection thing. And once reasonably you are sure that there is no infection, what are the things that guide you? A BAL, a blood culture, CRP, a procalcitonin. So whatever help you can get, you must take.
I think Priyanka, you've got your answer. You have responded that the patient presented with mononeuritis multiplex and his weakness was increasing.
And WBC count was increasing, is it?
Yeah, WBC was high.
So the mononeuritis was worsening on treatment, is what you're saying, no? If the patient has a disease which is not getting controlled, and you're reasonably sure that there is no infection, I think you should step up the treatment. Regarding mononeuritis multiplex, since you've raised this point, I would say that sometimes, they have persistent numbness or persistent tingling, but there's nothing new that is happening. So that is also something that you must keep in mind, that sometimes there is a residual nerve damage which occurs. Residual weakness remains. So you have to be able to distinguish from a new onset or a worsening from a, say the patient had 3-4 months ago and a mononeuritis multiplex, but when you see the next visit also, there is some numbness remaining. So that residual thing sometimes remains. So again, the activity and the damage, that also has to be assessed.
Any other doubts? Any other queries does anybody have? If not, then we'll call it a day. Sorry, Dr. Vandraj.
Okay.
Dr. Vandraj is having a question. Patient having ENT involvement, pulmonary nodule, microscopic hematuria, MPO was positive, P-ANCA MPO was positive. Still be diagnosed as vaginous, or we should think in terms of MPA as well? And second is a biopsy must to differentiate between these two?
No. So if you looked at the slides, unfortunately, I'm not going to be able to go to the slides. You will find that C-ANCA and P-ANCA can occur in, like C-ANCA can occur in MPO and P-ANCA can occur in vaginas in a percentage of patients, around 20% or 15 to 20%. So the clinical picture, and in fact, ENT is a point against the diagnosis of MPA. Again, if you look at the criteria, if you have ENT involvement, it's a point against MPO or microscopic polyangiitis. So go by the clinical syndrome that we have discussed, and sometimes you can get P-ANCA positivity in a vaginous or a C-ANCA in a MPO. Okay, and there's a big category of ANCA negative EGPA.
Anybody with any other doubts, questions?
Hello. Am I audible?
Yes.
Yes.
Hello.
Yes.
Ma'am, is it possible that patient has developed vasculitis post-infection and after a few days or months altogether, the infection component has settled down?
Yes.
By any means, we don't know because the patient came after a few months in OPD or in a peripheral patient. The vasculitis renewed, but infection has settled down somehow. Is it possible the scenario?
The infection has settled, no? And the vasculitis persists. Is that what you're saying? Yeah, but you know,
Yes,
whenever,
ma'am.
so sometimes you have this history of an infection followed by what looks like a vasculitis. It's quite likely that this vasculitis, particularly if it's a more benign kind of or limited to the skin and things, that it may just settle completely. Okay. So you can give a time of about 4 to 6 months. These kind of vasculitis sometimes may settle. Okay. So the acuteness should always make you consider the possibility of a post-infectious vasculitis. And you may not be 100% ever able to predict. But if your ANCAs and all are very strongly positive, then it's possible that this is going to be a persistent vasculitis.
Meantime, patients are very resistant for these channels to do and go underwent. So I have to presume that is it colitis clinic.
No, I didn't get the question properly.
Can you post in the chat?
You told me that PNFA. Yes. Hello.
Yes.
You told me that PNFA positivity will give you the possibility that having is sure, but peripheral settings only to the clinical part. The patient's relative are not very ready for such a panel to go with investigation part. I'm saying.
See,
so I had one patient in OPD that she came with the complaint of she had history of chicken pox, skin rash was there. After that, she took some treatment somewhere else in coag bounce. And after that, 1 to 2 years, she's continued with the complaint of joint pain, skin rash, with the alopecia component was there. Uh, anemia was also. So she was investing for ANA, DSD, and SLE was primary where the initial thing. But that came negative. And after that, patient lost to follow up. And after 4 months, patient came back again in OPD with similar complaint. The
See,
infection part was held down. She had no complaint of chicken pox, everything. But now the panel was still pending.
okay. No, but Dr. Salman, see, when we looked at pathogenesis, we saw that genetics also plays a role and an infection can trigger. So in a predisposed host, an infection may trigger the onset of an autoimmune disease, which then may persist, right? And in some patients who have a post-infectious vasculitis, it may subside within the next 4 to 6 months. So again, time, follow-up, all these for clinicians is very important to, even if there's an infectious trigger, but in a genetically predisposed host, that infection will trigger the onset of ANCA vasculitis.
Okay. Thank you.
Or any other autoimmune. You were mentioning something like lupus, but so it can trigger the onset of an autoimmune disease as well. So are there any more questions? Or I had just one thing to ask of particularly the teachers who are present, that, we are coming to the end of our sessions now. Isn't that right, Shashank? We have only 1 or 2 sessions. So we would actually like to know absolutely frankly from you, because, we don't want to force ourselves also upon you. But if you feel that this is benefiting the students, that is, then in which way we should continue this further? Or first of all, should we continue this further for the next year? Should we just be repeating the same series, or should we do a case-based thing? I mean, predominantly cases. This is what we would like to know from you all. And we will put it up on the group, and you can take your time and give your feedback, because it's actually meant completely for postgraduate students of medicine. So if you feel it's helping you, we are very happy to continue. If you feel the format should be changed, we are happy to do that. But we need your inputs for that. So,
We really need this feedback from all of you.
Yeah, so please give us your honest feedback. We will not mind, even if you say that it's of not much value to you. That's also will be acceptable. But if you feel that we can improve also in certain ways, please let us know. Give your suggestions. And if you want it more case-based, or if you want that, the students will present case and some of us will discuss, that also can be done.
Dr. Avlekar has written good academic activity. We will add more PG students next time onwards. So
no, I mean, we would be very happy to continue, because the aim is that we want a rheumatology awareness, more across the state. And this is just a year. So, I mean, a year is nothing. But so your suggestions really are very welcome.
Rohini, the lectures are very good. And in fact, we as teachers are also benefiting.
No, I'm glad you to hear that. But if you want the format to be changed, Nitin, we can change.
Maybe for 6 months or so, if we take a case-based discussion, whatever we've learned in these theories can now be practically applied.
And if you have some difficult cases,
So maybe we can involve the students, make them present.
Yes. Absolutely.
Take an opinion. So that will be two-way discussion, and we will learn more, I think.
Yes. Yeah. Okay. So thank you all for your good interaction, really, and enjoyed it. So see you all again at one of our later meetings. Thank you.
Thank you all. Let's meet again after 2 weeks with a new session. Thank you again.
Thanks, Shashank.